طيب نبدأ. بسم الله الرحمن.
توكلنا
طيب،
على الله.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this scientific event, in this wonderful evening where we are going to be gathered to discuss a matter of pressing global importance, the burden of influenza and the vital role of vaccinations. And I would like, in this regard, I would like to thank the Saudi Society for Family and Community Medicine for having this scientific event under the umbrella of its scientific committee. And I would like to extend my thanks to AstraZeneca, for sponsoring this event. And a special thanks goes to Paxes for their organizations of this event. And we have been privileged here, ladies and gentlemen, today to have two eminent, prominent speakers, and they are very dear friends of mine, in fact, and we have been working together for many, many years to disseminate this information of updates in infectious disease as well as the vaccinations as an important tool to combat the pandemics and epidemics and the disseminations of these infectious disease. And as you know, today we are going to talk about the influenza infection and vaccinations. And of course, as you know, influenza often perceived as a routine seasonal illness. And every year there is always, in this kind of season, which we usually encounter, there is a high prevalence and high incidence of respiratory-related death worldwide. And the impact of these viruses of influenza usually targets certain population with a special focus on the elderly populations and the young children and the pregnant women. And these are the target population. That's why we have to identify those people to be at risk of the infections. So with these burdens and the death and the financial impact, the influenza vaccine remain our most effective tool to defend our populations and the community. And it usually promote the protections for individual, reduce the transmission of the disease, and prevent the outbreak and save lives. But ladies and gentlemen, in spite of all these benefits that we always talk about, the vaccines usually uptake remains suboptimal. So all of us as a healthcare providers, we might be engaged in screening, diagnosis, and treatment, but there is another important tool after recommendation of vaccination is to educate people and to educate the public and the community about the benefits of vaccine and to combat the problem of vaccine hesitancy. So I'm very privileged today to have these wonderful sessions because I'm sure that this session will add a lot of updates and will enhance our skills and change our mind setup towards the importance of vaccination with a special focus on influenza vaccine. So today we have been privileged to have the first speaker, Dr. Tariq Al-Musawi. He's a professor and a senior consultant in internal medicine and infectious disease and critical care medicine. He's a chief of the ICU department and chief medical officer at Dalla Hospitals and at Al Khobar, the Kingdom of Saudi Arabia. So he's going to talk about the influenza virus infections and complication, global, local burdens, and influenza to vaccine, the ever-evolving target. So I'm sure that you are going to have a wonderful sessions and a lot of information that you will gain out of this session. And I would like to thank, on your behalf, ladies and gentlemen, Dr. Tariq for accepting our invitations and coming all the way and spare his time to give us more information and updates about influenza vaccine and the influenza infections. So thank you, Dr. Tariq, and I would like to leave the floor for you. But before that, I would like to remind you, ladies and gentlemen, that please keep your questions in the Q&A box, so I'll be able to collect those questions and forward it to our speakers as we go at the end. So we have the first session by Dr. Tariq, the second session will be by Dr. Nisreen, and then we'll open the questions at the end of this event, inshallah. Thank you so much for being with us, ladies and gentlemen. I would like to leave the floor for Dr. Tariq. Dr. Tariq, the floor is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good evening, everyone. It gives me a great pleasure to be here with you today I would like to thank the Saudi Society of Family and Community Medicine in inviting me over. It gives me always that pleasure to take part in their activities. I happen to contribute to prior activities in the future, in the past, and I look forward to continue doing so in the future, inshallah. Thank you very much, Dr. Ashraf, for this kind introduction, and to the scientific committee and the coordination of Dr. Abdul Hafid and the other colleagues. So without further ado, I will give the first half of this session, and then my colleague, Dr. Nasreen, will take care of the other half. So really quick, we've all had our chance to know what the journey looking like of influenza pandemics. That has been throughout the history, many of those episodes of epidemic and pandemics. One that we all lived was in 2009 with the swine flu influenza. But this has been going on throughout the history between influenza A and B viruses, bringing about problems to humankind as far as infections are concerned. Little virology to make things understandable when it comes to disease burden, clinical manifestations, and even possibly vaccine preparation. Influenzas are either A, B, or C. Now, just before I take it further about A and B, influenza C is extremely rare to occur in humans because it can infect animals mainly. And if it occurs in humans, it causes very mild disease. Influenza A and B are the real deal, and these are the ones that are contributing to significant morbidity and mortality, and then the one that we get the vaccine against. Influenza A is composed of important components, of which N it refers to neuraminidase, and HA stands for hemagglutinins, out of which there are 18 H's, which is different hemagglutinins, and the N's there are 11 in neuraminidase, and subsequently you hear, for example, H1N1, H5N3, and so on and so forth. So these are coming from those projections that are within the outer wall of the influenza A. Influenza B, on the other hand, have two major sublineages, either Yamagata and Victoria, and I think that is probably all what you need to know as far as influenza A and B and how their composition and sublineage and clades contribute to the compositions of the influenzas in the past, the current, and even in the future vaccines. Why do we have to take a vaccine every year for influenza? Why is it not one-time shot in our lifetime, like many others, and we get boosted like typhoid, for example? Is because of the variation of the influenza virus that comes from two major well-known phenomena. The first is called antigenic drift, and that usually occurs if you look in the far right, the diagram indicating of some point mutations that takes place and make changes in the virus, or what is something that may be bigger, we call it antigenic shift, which is also referred to as reassortment, when not only a point of mutation, but large segments of the virus are being exchanged between one another. That usually occurs when two viruses are infecting one human body or an animal that reassort to bring about one new virus that leads usually to pandemic. And this is what it was thought to be 2009 H1N1 pandemic occurred through a reassortment or antigenic shift. The timing and duration of the flu season vary each year. So we know that there is already a variation related to northern or southern hemispheres of the globe, but even in each country, it would vary by some degree. Now, some degree, a tiny degree of few days may not make a huge difference, but a month change will make some difference. Look at that, for example. The peak in the United States in February, the peak in Europe is in January. And we have our own share too. In the Kingdom of Saudi Arabia, we have probably the second half of October towards the first week of November is the peak. Now, this is an issue because sometimes vaccination campaigns may not correlate with the influenza season start. Now, in countries where they manufacture the vaccine and then they adopt the vaccine towards their communities, they will target it right on time. in countries like ours, when we don't manufacture the vaccine and we receive it imported from other places, depending on what the supply chain delivers the vaccine to us. And then sometimes we may not completely align the timing, because we may not have the vaccine received to us in the right time. The influenzas, whether A or B, they contribute to a global burden that is very substantial, with millions of people being affected every year. There's around 1 billion global cases of seasonal influenza annually, contributing to major significant hospitalization, and among those hospitalized, lots of complications, out of which respiratory complications are the number one in the form of pneumonias, sinusitis, or acute bronchitis. There are also well-known cardiac complications among inpatients that we have seen over the years, like myocarditis, pericarditis, or even exacerbation of cardiac diseases, specifically heart failure or cardiomyopathies. And there are the neuromuscular complications, and it's a form of encephalitis or aseptic meningitis, and so on. And then these complications with other comorbidities certainly would contribute to significant mortality. Although influenza mortality is still considered relatively rare compared to other diseases, highest rates are observed among infants and older individuals. You see there are extremes among the people who are less than 5 years of age, from 2.1 to 23 cases per 100,000, or those in the other end of age, like more than 75, we see 51 to 99, or almost 100 per 100,000 cases of influenza annually. So this is really considerable. If you look at people who are young and middle-aged, like those less than 65, you see it is the least, from 1 to 5 cases per 100,000. So this is the mortalities, and if they were to occur, will occur in the two extremes. Now, influenza specifically is highly transmissible and can cause serious complications, some of which I have already alluded to, particularly at those of high risk. And the symptoms between mild, moderate, or severe almost involve every organ system. There are some people who are more vulnerable to these complications and to further disease, like those with asthma, chronic obstructive pulmonary disease, cardiovascular disease, specifically cardiomyopathy, coronary artery disease, and heart failure, patients who had chronic kidney disease, who are undergoing hemodialysis, cirrhotic patients, and those with chronic liver disease. Pregnant women are more vulnerable than the average women with equal age, but not being pregnant, certainly bring about more morbidity and possibly even mortality. Now, respiratory deaths rate from seasonal influenza among those above the age of 65 had been looked into in many countries, and then unfortunately in the Kingdom of Saudi Arabia, as well as some other neighbors like United Arab Emirates, we tend to have a relatively higher rate than some other countries due to different reasons. Certainly the catchment of the vaccine is one of them. Let me talk about burden of influenza virus in children, because I intend to link describing this to further strategies related to vaccination among children. So the presentation of influenza in children may differ from adults, as children may, all what they have related to influenza is redness of the nasal and pharyngeal membranes without an oxidate, or sometimes some excessive crying or runny nose, or even mild temperature elevation of 37.8. So they may not necessarily manifest a full-blown disease, although it may sound like this is a mild influenza that is unlikely, to lead to complications. But sure enough, it may start like that and even end with death, which is still possible. So the presentation of influenza may look milder, in some children, or it may present frankly as a pneumonia or acute bronchitis with subsequent complications. These are some diagrams that shows seasonal influenza attack rate are highest in children with morbidity and mortality affecting both ends of age spectrums. Look at the neonates or the very elderly people, like I have alluded to, are those that are more likely to be vulnerable to this disease. This is another diagram that is possibly showing the same, that the mortalities are at the extremes of age. Look at those which are from weeks up to 1 to 2 up to 4 years, and subsequently those who are older than the age of 65. But for children who are less than 7 years of age, they happen to have the highest risk of influenza-related complication and even antibiotic use, because you can imagine many respiratory as well as bacterial infection are almost identical in the way that they would present. And moreover, influenza can precipitate and invite bacterial complications to further occur. If we look at 3 segments of age group of children less than 3, 3 to 6, and 7 to 13, you would see in the left graph that there is the pneumonia, sinusitis, and acute otitis media. And then on the right, you see corresponding antibiotic prescriptions and use given accordingly to different complications related to influenza. Although it is influenza, it's not a bacterial infection, but there are many times when it is not possible to discriminate between virus and bacterial infection. Although in general, the pediatricians are more conservative with the use of antibiotic, yet the influenza or other respiratory viral infections would push towards prescribing antibiotics when the picture is not very clear, or when the concern about co-bacterial infection is of a great concern. Now, the majority of influenza-associated hospitalizations occur in healthy and unvaccinated children. So if influenza would occur, we know that the vulnerable children with immunocompromised state may get influenza more than the average. This is understood, and that holds true for influenza and other infections. But if you look at influenza per se compared to among the healthy otherwise children, it would occur in the healthy one who happen to be unvaccinated, like you see in this diagram. And then children experience a substantial number of annual hospitalization with older children. So the children, if you see in the diagram above for ICU admission or mechanical ventilation, happen to be those who are above the age of 8. So they are closer towards teen years, like from 8 upwards until, depending on what definition of pediatric age group, in some countries up to 17 or 18. And when you see that those who are older children, like 8 and more, are likely more likely to get severer disease that may require ICU admission, including supportive measures with mechanical ventilation. The matter is not only inpatient per se, but it is every sector related to healthcare services. So in low pediatric vaccine coverage settings, children are overrepresented in many primary healthcare services, emergency settings, and hospitalizations. So you would see when the vaccination rate of children is low, you're likely to see them presenting in ERs, in urgent care centers, in family medicine clinics, in ICUs, in general pediatric floors, and so on and so forth. They would compromise the healthcare services because of the burden of the disease. Some studies have indicated that up to almost 35,000 children die from seasonal influenza, with 50% having no risk, like absolutely healthy, for severe disease, and 70% being unvaccinated. So they have looked and they've seen those who would really get affected among the children with influenza happen to be missing the influenza vaccine. Now, this is a very, very important slide, is that compared to other children, or compared to adults, incidence of symptomatic influenza is 70% higher in children, and children shed the virus 50% longer than the adults. And this is a very important epidemiological characteristics that contribute to further transmission of this within the community, that drives caregiver absenteeism and community transmission to family members and to other children and vulnerable adults. There is a very important tool for children in transmitting the virus to others, specifically adults or elderly. Look at this photo in the down. There's a family. There is one young child who is between the two faces of the grandfather and grandmother. All what it needs for him is to sneeze, and then and then if he happened to be shedding the virus, that the elderly become very vulnerable with it. And vaccinating children against influenza would have an indirect protection to the whole community. There is some studies that came mainly from England that have proven this. This is the impact of the UK childhood vaccination program in the year 2014 to 15, showing that the GP consultation for influenza-like illness in the pilot versus non-pilot areas in England shows a significant difference. And moreover, this is even more essential that if you vaccinate children, that you will see adults are presenting to GPs with influenza-like illness is far less. A very, very important concept. And I look forward with you to listen to Dr. Nasreen, and then she can elaborate more on these aspects related to how the vaccine would control the transmission of the disease within the community. Now, I have shown you that children have a high impact, especially older children, for the disease. But how well do we do? Look how great we do for the children vaccination related to things like DTP, Hep B, Haemophilus influenza, and so on. Look at that percentage of influenza on the far left in orange, that we are not doing as well as we with the coverage of influenza like we do for the other mandatory vaccine. And then we leave children bare, susceptible and very vulnerable to this bad infection if it were to occur. Now, few words from virus to vaccine. The vaccine has become, our vaccine is the only and the best preventive way that can handle influenza. There are primary means to prevent flu is through vaccination. These are different organizations that have advocated for the need for influenza vaccines, like the WHO, the Central for Disease Control and Prevention, and the corresponding one in Europe to it, which is the European Center for Disease Prevention and Control. They all concur with the fact that the best way to prevent, to deal or to manage influenza infection is prevention. And the best preventive tool we have is through vaccination. What has changed over time related to the vaccine that may be worth looking into specifically related to vaccine of children is that it is no more that the sublineage of B. Yamagata from the circulation since March 2020. And now when we compose or design vaccines that should target children, we do not need to do the quadrivalent vaccine, which has been taking place for quite some time. And then the intention is toward a trivalent vaccine, which include the A2 types and only be Victoria sublineage and not the Yamagata for the reason that I have mentioned. So this is what is thought to be what is suitable for the current epidemiological state that we're having right now. If a vaccine is to be composed of two variants of A, H1 in one strain and H3 in two strain, and among the B is only the B Victoria lineage and not the Yamagata anymore, because it has not been circulating for a quite period of time. And you notice that if you remember the very first slide, that there is influenza C is not, it's completely outside the calculation of the vaccine because it causes very, very mild disease. Here is the kind of Saudi Arabia flu vaccine recommendations. And then you could see, if you look carefully, and then you open the platform of the Ministry of Health, and then go after the influenza vaccine, there is almost everybody is indicated for one way or another to receive the influenza vaccines. Certainly people at higher risk with comorbidities, a lot of people that I have mentioned throughout this presentations, including diabetics, hypertensives, chronic renal disease, liver disease, pregnant women, obese patients, children aged 6 months to 5 years, and then even 6 months to 18 years on long-term aspirin therapy for whichever reason, and so on and so forth. There are a lot of indications for different patient population to receive influenza vaccine annually. So few words, and then I would conclude just to talk about some inactivated and live attenuated influenza vaccine, and perhaps Dr. Nisreen had something further to offer to you too, is that there are the inactivated or killed influenza vaccine are non-replicative and they are made up of viral components, but only quantitative hemagglutinins that you see in the far left. And then intramuscular delivery drives a systemic immune response. There is the another, which is live attenuated influenza vaccine, is made up of attenuated disease containing different components from circulating viruses. Vaccine viruses are throughout that replicate within a drive protection. I think I have a better photo that can show you that. This is how the trivalent vaccine is so much simulated, the live attenuated is so much simulating that the actual influenza virus, except that it is being weakened, that it cannot replicate and cause disease, but it can very much simulate the pathophysiological process. And then the thought is, if it is given in the nasal cavity, it could initiate the immune response, something very similar to the pathophysiological evolvement and process of the virus from being acquired, from the acquisition moment until it causes disease. So it's a nasal spray that will rely on the temperature of 33 degrees Celsius within the nostrils, and it would replicate in the mucosa, leading to generation of local antibodies within the mucosa, which is the IgA, and then subsequently it will reach the systemic circulation, stimulating the cellular immune response in the form of T cells specifically, and some of the B cells that will help also generating some IgG antibodies. A process that it really simulates what it would be like for a child to receive or to acquire the influenza virus. So you see here there are the live attenuated influenza virus provides immunity through 3 immune pathways. One is the primary mucosal IgA response in the nostrils, and then the systemic IgG response to some extent, but also very importantly, systematically through the T cell response. And this is another representation of what I have just said. So it's the mucosal IgA and the T cell response are the primary immune components to this type of vaccine, and the serum IgG maybe to some extent. So this showed the timeline and how we have changed from the quadrivalent to trivalent for the reasons that I was mentioned, that the B Yamagata sublineage is not anymore circulating, at least for the past 12 to 14 years or so. So with that, I would conclude and say that influenza virus complexity comes from the drift and shift, and that is the reason why it would require a yearly vaccines to be given rather than other types of infections, which may you may take only in one lifetime. Timing and duration of the flu season vary each year, and that has needs to be calculated epidemiologically well in order to have successful influenza campaigns. Global burden of influenza is substantial, and I have shown you how that can affect elderly and children alike. The majority of influenza-related morbidity and mortality occur in healthy, older children and the unvaccinated one, where we are not doing very well. And I have showed you how influenza coverage in these children is far less compared to the other standard vaccine, which are part of the national immunization programs. Children, compared to adults, shed virus 50% longer and contribute significantly to virus spread in the community. And then finally, live attenuated influenza virus trivalent vaccine offer long-term protection via mucosal IgG and T cells, and perhaps some through serum IgG as well. With that, I conclude, and I'll be very happy to take any of your questions in the Q&A session. And I look forward, like you all, to hear from my fellow speaker, Dr. Nisreen. Thank you very much.
Thank you so much, Dr. Tariq, for this wonderful illustrated presentation. You shed lights on the influenza virus, going through the burdens and identifying the risk population, the recommendation of Ministry of Health, and finally you highlighted the life-attenuating influenza vaccine, the trivalent vaccine. So thank you for the wonderful, smooth, simple, and enlightening presentation. And now, ladies and gentlemen, we'll go to the second speaker, Dr. Nesreen Sherbini. She's a consultant infectious disease, head of the infectious disease department, and director of Saudi fellowship in infectious disease training, Prince Sultan Medical City in Riyadh. She's going to talk about immunizing healthy populations and the importance of childhood vaccination. So another important session for us to learn from Dr. Nesreen, the updates and the important information that we need to know to promote this vaccination for children. So thank you again for Dr. Nesreen for being with us here today, and I would like to leave the floor for you.
Okay. Thank you very much, Dr. Ashraf, for the nice introduction. I'd like also to thank the organizers for inviting me and my colleagues to participate in this important webinar before the winter season. And as mentioned by Dr. Ashraf at the beginning, although it's not the season of influenza, however, we're seeing a lot of sporadic influenza on and off. So my presentation will be focusing on the importance of childhood vaccination. I thank Dr. Tariq so much for extensively talking about the situation of influenza infection in childhood. So this will make my job much easier. Let me share my slides. Okay.
Okay.
Can you see it?
Yes, we can see it.
Okay.
Need it full screen.
Yeah. And it's not yet.
No, it was there, but it went away.
Okay. Now I think it's
Okay, can you
okay.
can you have a full
So
screen?
yeah.
No.
طيب بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا وسيدنا محمد صلى الله عليه وسلم وعلى آله وصحبه أجمعين. And good evening, ladies and gentlemen. So the title of my talk is about immunizing healthy population and the importance of childhood vaccination. I have no conflict of interest. These are the contents of my talk. I'll try to cover each point quickly over the coming 20 minutes. So as Dr. Tariq mentioned in his lecture, the high-risk groups to get severe influenza and complications and requiring hospitalization, ICU admissions, focusing mainly on age-related group are the children below 2 years of age, specifically those below 2 years, and elderly people 65 and above, pregnant women, and as well as patients with certain comorbidities such as bronchial asthma, chronic lung diseases, cardiovascular diseases, chronic liver disease, diabetes, which is common in Saudi Arabia, and morbid obesity, immune-compromised patients, including HIV, and so forth. Why this is important? Probably you saw already this slide by Dr. Tariq, because influenza can cause a mortality annually worldwide of around 250,000 to 500,000 each year dies from influenza. And of course, the mortality is at the end of the spectrum, those below 2 years or 5 years sometimes, and elderly people above 65. However, the influenza attack rate is much more higher in children compared to adults. As you can see here, it's double compared to adults. For every for every 20 adult, one gets infected with influenza. However, it is 1 in 10 in children. And the same for what we mentioned initially, the most effective measure to prevent influenza consequences, morbidity, and mortality is vaccination. For example, in this data from the United States in the season of 2018-2019, when the coverage rate was only 49%, which is not optimum. However, they could reduce the influenza cases by more than 4.4 million. During that season, they prevented 58,000 of influenza-associated hospitalization and more than 3,500 of influenza-associated deaths. Now, these are some important definitions. I thought we should know it before I proceed further. There's something called vaccine efficacy and vaccine effectiveness. Vaccine efficacy, it's about the protection exerted by the vaccine in clinical trials, meaning that the situation is ideal. And the vaccine effectiveness, it's the vaccine protection given by the protection given by the vaccine in the real world data. So, for example, when we say vaccine has efficacy of 80%, this does not mean that the vaccine only can work in 80% of the time. It does mean that a vaccinated population or 80% can have fewer risk to contract the disease. Another term is called vaccine herd effect, and this is the extra protection of non-immune high-risk persons with increased immunity among vaccinated healthier persons, such as children. And the herd immunity is the immunity occur in the community. Sometimes it's known as community immunity or indirect immunity, when enough people or large number of people are vaccinated. So a few words about influenza vaccine in elderly and chronically ill persons. Despite the relative success in reducing laboratory-confirmed influenza virus in children, with vaccine efficacy reaching up to 66%, however, this is considerably diminished in elderly people, especially those in nursing home facilities. And this is related, of course, to the immunosenescence and the presence of comorbidities. In a systematic review, the effectiveness of seasonal influenza vaccine among elderly was demonstrated to be of limited benefit. In long-term care facility, the trivalent inactive influenza vaccine effectiveness to prevent acute influenza illness was only 23%, and it prevented pneumonia due to influenza in about 46%, and influenza pneumonia and death in 42%. So it is lower compared to the children. Moreover, vaccinating selected population is unlikely to reduce the entire burden of seasonal influenza since the majority of infections circulate among younger age group. Accumulating evidences are supporting immunization of extended population with regard to the vaccine herd immunity. Now, immunizing healthy population, in this randomized double-blinded study among health care professional, their number was 361 during the winter season. It resulted in laboratory confirmed influenza reduction by 87.3% and absenteeism from work in around 53% in the vaccine groups compared to the non-vaccine group. And this data support a policy of annual influenza vaccination of healthcare professionals, even if they are healthy and they have no comorbid illnesses and they are not old. In Japan, the school children vaccination started in 1962 and it was stopped in 1987. So it was for around 25 years. When they stopped this program of vaccinating children with influenza vaccine, what happened? They started to observe winter pneumonia, increase in influenza mortality. So that gave them the clue that the observation that the influenza vaccine for children in school were indirectly reducing the influenza mortality and morbidity in the community. This table summarizes some of the studies of showing the vaccine herd immunity. For example, in this study, it was a bit old in 1970. It was conducted in more than 3,000 school children. In that city, they vaccinated the children and they used a monovalent inactive vaccine. And when they compared the outcome to another city where the school children were not vaccinated, they found that the vaccinated group in the city, while they vaccinated the school children, there was reduction in influenza A in the entire age group. Another study by Ipsitu et al. And another study also in the same year, 2003, Principal et al. Both they studied the vaccinating influenza in children with recurrent respiratory infection, and their outcome is to measure the respiratory tract infection in the two groups. Again, they found that the vaccinated group compared to non-vaccinated group, there was a reduction in the influenza or the vaccine efficacy in the contact to the vaccinated group was 24% in the first study and 30% in the other study. And both studies, they used trivalent inactive influenza. In the first study, they used the live attenuated influenza vaccine. The other study, they used the inactive influenza vaccine. And the last study was a bigger one. It was conducted in Canada in children again and adolescents. The number was 947. And their outcome is to assess the laboratory confirmed influenza. The vaccine efficacy in that study was really considerable, 61% efficacy in non-vaccinated group, which were a contact of the vaccinated group. So this is slide already shown by Dr. Tariq, what is the role of children in the transmission of influenza. Although sometimes they don't have fatal influenza disease requiring hospitalization, especially if they are above 5 years. However, they play a major role in transmitting influenza in their household, in family member, in the school. So as mentioned again by Dr. Tariq, because basically they have high attack rate of influenza and they are shedding the virus for longer than older younger group. Sometimes they shed the virus for 1 week or 10 days. Again, this slide was also shown by Dr. Tariq. Despite the significant burden of influenza in children, however, as you can see here, the coverage rate is not optimum compared to the adult. Although in adult, in this study, it was not optimum. It was only 51%. However, in children below 14 years, it was only 28.9%. So now coming to the type of influenza, you can figure it out that we have two types of influenza: the inactive influenza vaccine, which can be cell-based or egg-based, and the live attenuated vaccine. And the third one is the recombinant influenza vaccine. Seasonal influenza vaccination strategy vary between countries. For example, in the United States, influenza vaccination is recommended for all people above 6 months. However, in Europe, it is largely recommended for the high-risk group, with exception of a few European countries. Live attenuated influenza vaccine is recommended for children because of the lower immunogenicity to the inactive influenza vaccine in this age group, as well as it is needle-free administration for those who have needle phobia. And in this table, I summarized the difference between the three types of the vaccine. For example, here the route of administration, it is by nasal spray for live attenuated vaccine. For the other vaccine, it is intramuscular injection. And it is, of course, live attenuated. It can stimulate immune response, but without causing serious or disease. The others are killed, and the third one, the recombinant, it's recombinant heme agglutinin proteins. The frequency, all the vaccine has to be given annually, and the age group, the recommended, as you can see here in the table. Sometimes in age group between 6 months to 8 years, they require more than than one doses, 2 doses, 4 weeks apart for the live attenuated vaccine as well as for inactive influenza vaccine. For the live attenuated vaccine, it should not be given for people at risk for serious influenza, meaning, for example, they are immune compromised, they have comorbid illnesses. It's not recommended. This vaccine was not studied in this group. Okay. Can the vaccine be administered to family members or close contact with family members immune suppressed? Yes, if they they do not require protected environment, and this is applied for all the three. However, if the family have a member with heavily immune suppressed, for example, hematopoietic stem cell transplant, then the live attenuated vaccine should not be given. It is contraindicated. And the healthcare worker or healthcare provider should take a history if the patient, if he's planning to give live attenuated vaccine, if the person receive antiviral for influenza, for example, oseltamivir, zanamivir, it has to be after 48 hours, and for piramavir it has to be 5 days, and baloxavir after 17 days. Otherwise, of course, the vaccine will not work because it is live attenuated vaccine. Again, this was so I'll skip this, but basically, if we look at this table, the live attenuated vaccine mimic the natural infection in terms of inducing strong cell-mediated immunity, as well as, of course, to humoral immunity and local immunity by stimulating the secretion of nasal IgA, and this plays major role in protection against influenza, like preventing the virus from entering the body. This I will not talk about it. It's just showing that the live attenuated vaccine similar in structure to the influenza virus. So the Russians were the first the first country to use live attenuated vaccine. They're using it now for more than 40 years. It's approaching 50 years. And it is also recommended in the state since 2003 for the age group between 2 to 49 years old. In Europe, since 2012 for healthy children between 2 to 17 years old. And UK, they have long experience with the administration of live attenuated vaccine in school children between 4 to 11 years, and they estimated the large national cost saving as well as reduction in morbidity and mortality due to herd immunity in non-vaccinated population. In other European countries, Finland, Slovenia, Germany, they also using this vaccine for this age group, the school children. So live attenuated vaccine is easily to be administered. As you can see, it can be given by a caregiver, for example, in school, or even self-administered in younger children, for example, in high school. It is well tolerated. It can mostly cause transient local side effects, which is usually transient in the first 2 to 3 days, in form of runny nose or congested nose. It is contraindicated in children with active influenza or wheezing, and other contraindication, of course, because it is live attenuated, it is contraindicated for immune compromised persons, pregnant women, and as I mentioned, in children with severe asthma. However, it can be given to people with a stable asthma, and in those receiving salicylate therapy because of the risk of Reye syndrome. This is the development of live attenuated vaccine, different forms, either trivalent, quadrivalent, according to the circulating virus. I would like to end my talk by mentioning this interesting study. It is published recently in February 2025 this year. It's talking about what if we increase the coverage of influenza in children. So they used something called a FRED, which is a framework reconstructing epidemiology dynamic. In this module, for example, here you can see the susceptible person when it is exposed to patients with influenza. This patient can be either pre-symptomatic, meaning that 24 hours before the appearance of the influenza symptoms, or those after 24 hours, they can remain asymptomatic and recovered completely. However, they still can be contagious to other, less contagious than the pre-symptomatic, but they can infect people up to few days before their recovery. And for the infected, if they are high risk, of course, they might require hospitalization, ICU admission, and death. So the purpose of this study is to increase the coverage based on the data from the CDC during the season 2021. The coverage rate, as you can see here in the baseline, these are the coverage rate at different age group. If we focus at this age group, between 5 to 12, the coverage rate is 58%. Between 13 to 17 is 49%, and as you can see, it is really lower than the older group and the during the first year of life. So if they increase the coverage to 5%, these are the figures, 10% and 15%. What will happen? We will see together. So this is the diagram. You can see here the colors that represent the coverage rate. The gray color represent the 5% increase in the vaccination in this age group. Blue is 10%, and the red is the 15% increase. So here, the direct effect of the vaccine on the concerned group. You can see, of course, compared to the baseline, with each increase in the coverage, we get more increase in having in reduction of the symptomatic cases, not only in the school children, but also extended this effect, the positive effect extended to the other age group between 18 to 49, as you can see here, and as well as in the older age group, but however, it is less compared to the younger age group. What about the hospitalization? It's really very impressive. The hospitalization rate, by increasing the coverage rate in the school children, was affecting the older people to this, as you can see here. It's very here. And the same in the table. The effect is considerable in the school age group. By 5%, we prevent the symptomatic influenza by 3.2%, 6.6 if we increase it to 10%, and 15% if we 10% or 11% when we increase the vaccination to 15%, and the same for the indirect effect in older age group. This is by considering the vaccine efficacy of 40%. If the vaccine efficacy is higher, 45%, we can even get more and positive impact, 7.5 by increasing 5% in this age group, and 15.6 impact reduction in the symptomatic cases if we increase the coverage rate to 15%. And the same if we look at this age group, 65 and above. In addition to the reducing the hospitalization, and as well as reducing the symptomatic cases, they extrapolate also, they calculate how much they can save the missed days from school and from work. So considering if each symptomatic child would miss the school for 1 to 3 days, then they can reduce missed school days by 261 to around 700,000 days from the US population. And the same for the also the missed days from work for the parents. They can save 130,000 to 262,000 missed work days. And this was by the effect of the quadrivalent vaccine, which was less effective compared to trivalent. So this vaccine efficacy and the vaccine herd effect might be even much better if the live attenuated vaccine changed to trivalent vaccine. So by this, I would conclude my talk. The seasonal influenza vaccine program in many regions aimed to protect most risk population, but it does not provide sufficient effectiveness on preventing severe outcome of influenza. This policy should not be discouraged because it is proven that it has independent value in preventing mortality related to influenza in high-risk group. However, we need to implement another synergistic, I can say, protocol, which is by using the herd effect of the seasonal influenza vaccine in terms of universal immunization, or at least immunizing people, children at school. This will potentially further protect vulnerable population under risk of influenza. Thus, vaccinating children against influenza had broad effects, and maximizing coverage in this age group would be expected to have significant public health impact. Trivalent live attenuated vaccine given to school children was associated with greater direct efficacy as well as herd protection among the community adult population. Traditionally, seasonal influenza vaccination program, including school vaccination, was considered as an important component of pandemic preparedness. However, we have to ensure the adequate supply, meaning that the universal vaccination program of healthy population requires increased global production of influenza vaccine. And by this, I conclude my talk, and I'm happy to receive any questions or comments. Thank you very much.
Thank you so much, Dr. Nasreen, for this wonderful presentation. You have highlighted the importance of vaccine for childhood vaccination, especially when it comes to influenza vaccine. And in fact, we have a very good questions now from the audience. And I would like to thank Dr. Bilal Mahmoud and Dr. Salahuddin for their wonderful questions. In fact, so we're going to start with the first question to Dr. Tariq. This is a question from Dr. Salahuddin. Saying, is shift and drift of the virus always towards severity or sometimes be less severe than previous initial attacks?
Very good question. So the most important thing about shift and drift is that you get a new virus. That's the most important thing. Now, that does not necessarily mean this virus is going to cause severer disease than the previous viruses or a virus with high mortality. But it is new in the sense that there is no prior immune system in the body, and then the body will deal with it as a new virus that it has to adapt a newer immunity towards it. So if it is especially the shift through the reassortment, if it is something that the outcome of the new virus is after reassortment, it is very likely that it's going to bring more symptoms, more disease, not because it's more virulent, just because the body has absolutely no prior immunity. It is so much different from what the body has been adapting to over the years, or it has no similarity from prior viruses. Now, let me take the example of the 2009 swine flu, the H1N1. Now, in many people, H1N1 caused very mild disease. In some, it led to ICU admissions. So it was not actually severer than whatever we were used to, except it was more transmissible. So a new virus brings about new characteristics, which would include anything, may include transmissibility, may include a longer shedding, may include severe disease. It is a matter of luck. That's what we go through a new virus.
Okay, thank you so much. So it's not usually
Not
become more
necessarily.
severe, not necessarily.
Absolutely.
Okay,
Yes.
it depends. All right, and this will take us to similar questions.
Sure.
Says, any impact of the previous vaccines on the effectiveness of the future flu shots? So if the person who is at risk getting on a yearly basis the flu shots, will this continuously having the vaccines annually will enhance the efficacy of the future shots in the subsequent years?
Yes, that's another very good and smart question. The efficacy of these future shots would likely to occur from a prior ones, but depends on how similar is the prior one to the current circulating one. So it may sound like by simple rationale and statistical method, Dr. Ashraf, that the more you get, the more your body exposed to, the more herd immunity within a community, like Dr. Nasreen has beautifully alluded to in her definitions. So if I get more, right, I'm likely to acquire some immunity from slightly similar viruses, until at times when a completely new virus comes in its majority of composition that the body does not have any prior memory of. And then it may cause certainly more symptoms or severe disease or even mortality. But prior viruses, yes, certainly adds to like prior infections too. They add,
Yes.
To further immunity.
Absolutely, you're right. So in the same context, Dr. Nasreen, we can encounter patients who says, we received the vaccine, but in spite of having the vaccine, we get the flu. So how usually you encounter and tackle this kind of claim by patients who are receiving the vaccine and getting the infection?
Yeah. This claim is very common, Dr. Ashraf, and sometimes we hear it even from our colleagues, physicians, in
Yes.
a different specialty. As we said, one of the reason is the mismatch, because the manufacturing influenza vaccine it takes 6 months for the vaccine to come to the market. During this 6 months, the virus keeps on mutating with the antigenic drift. So the vaccine we have, that's why it's one of the causes that the vaccine efficacy is not really optimum. It can be up to 60-70% in younger age group. However, in older age group, for example, because of immunosenescence, it's even lower. Because of one of it is the immune system and the mismatch. The other thing, we cannot guarantee that if every flu is meaning influenza. We have, especially during the winter time, we have different viruses, RSV, metapneumoviruses, many other respiratory viruses that you cannot differentiate between them clinically. The only way is to do the, of course, the PCR by the nasopharyngeal swab, and this is not needed most of the time if it is mild and self-limited. So this is most of the time my answer to to people saying that.
Okay.
How
And I think
another thing that when we say it is preventing, we mean that prevent severe disease, complications, hospitalization, ICU admission, but not preventing infection, pre-symptomatic or mild infection. This is another also
okay.
probable
Well
answer.
said, Dr. Nasreen. I think this is the answer of the questions of Dr. Bilal Mahmoud, who asked the question, does the influenza vaccine get updated to match a new viral traits, and how effective it is against the rapidly evolving strains? So
Yeah. If you allow me, Dr. Ashraf,
yeah, please go
I
ahead.
think, yes, I would really and strongly concur with the points mentioned by Dr. Nasreen, in regards to the question addressed to her. And then maybe one more factor, Dr. Ashraf, is also the timing. remember, there are when she said the mismatch. So the mismatch is sometimes people study the expected circulating virus at the time, but and they prepare the vaccine over several months, and then they deploy the vaccine. They deploy it after certain few months when things have changed in reality. And also, and that's the exact mismatch. Or also sometimes you're so ready with what you're supposed to deploy, but you don't get it on time. So people may get infected before the campaign started, and that's why what I have alluded to. So it makes a difference in each country when the peak of the influenza to design the campaign. Now the question, the last question is, you said, Dr. Ashraf, the timing, is that what you said?
Yeah, does the influenza vaccine get updated? No.
See, the virus doesn't get updated. There was a few slides that I thought that would be very complicated for non-specialized in infectious disease or vaccinology people to understand how they could somehow predict what the viruses could be. So they study certain drifts and shifts phenomena that are occurring in the virus within expectations, because and then you have sublineage and sub types of viruses that are all included in one vaccine. Although there are three main types, but there are variants of these types to be as inclusive as possible with whatever it could be coming up. There has been years, and not long time ago, if I recall, maybe 4 or 5 years ago, when it was complete mismatch. The prediction was one thing, and the reality was absolutely something different. And this is one of the highest burden of influenza seasons known to us, because the prediction did not really match the reality.
Okay, thank you so much, Dr. Tariq. And I think we have also questions from Dr. Bilal Mahmoud. Can we give inactivated influenza vaccine to the person having fever or active symptoms of influenza infections? He's talking about the inactivated influenza vaccine. Dr. Nasreen?
It's preferably to avoid vaccination in febrile patients. So
Yes.
once the fever subsides, then he can receive the vaccine. Can I just add to Dr. Ashraf to the first question for the one who asked if we can, if the vaccine is updated,
Yeah.
can we give a protection? This is why we are talking about this evening about the live attenuated vaccine in certain group. Let's focus on the school children. Because this vaccine is different from inactive influenza vaccine, because it works locally at the nasal mucosa. So it stimulates the secretion of IgA secretory antibodies, as well as stimulating B cells and T cells to secrete in serum antibodies of different antibodies, IgM, IgG, and IgA in the serum as well. So it gives additional protection. So I think by doing that, we can increase, by using the vaccine, as I said in my talk, vaccine efficacy, herd effect. By vaccinating this group, we can give more protection to the community, including the vulnerable population, older people, people with comorbid illnesses.
Okay.
So it's like additional policy or protocol to be considered.
Excellent. Dr. Nasreen, there's a question also for you from Dr. Samir Afifi. He said, what is the benefits of having the live attenuated influenza vaccine in contrast to the inactivated, despite it has many limitation, precautions, and contraindications? As you have said, there is some contraindications regarding children under the 2 years, adults 49 years, pregnant, and immune compromised. So what is the value when you compare the inactivated versus the live attenuated influenza vaccine?
Probably probably I just answered this part. They are not a lot. The contraindications are certain contraindication. Pregnant women, immune-compromised patients, and it's not contraindicated in children.
Under 2 years.
Yeah, and it's not contraindicated in children under 3 years. It can be given for children from 2 years and above.
Mhm.
So we can use this technique or in the vaccination program for influenza in addition to administering an active influenza vaccine to the other groups, focusing mainly on the children who play a major role of spreading the influenza to their, as we said in our presentation, to their family members, to the other people in the school. Among those who might be those at high risk group, pregnant women, older people, immune compromised. So it's like additional protection to the community and to the vulnerable.
Any risk for viral shedding, Dr. Nisreen, by using the live attenuated influenza virus?
It is attenuated. It does not cause disease. However, it is contraindicated in heavily immune compromised patient, as well as if there is a family member with immune compromised hematopoietic stem transplants who needs a protected environment. But if they have family members who are immune compromised but they are stable and they don't need protected environment, it can be given to children in that family, for example.
Okay, thank you so much. طيب, I think this was the last questions, and before we close, I would like to ask each one of you to say a final statement, to encourage physicians to participate actively in promoting and recommending the influenza vaccine when it comes to the live attenuated influenza vaccine. So what would you like to say, Dr. Tariq and Dr. Nasreen?
Yes. Thank you, Dr. Ashraf. So I think it's a wonderful concept to know that through live attenuated influenza vaccine, vaccinating children to have a community protection. As a matter of fact, this concept, which has been studied for influenza now and has been proven in some British studies and some other studies that Dr. Nasreen had beautifully illustrated to us, is taken into another level. I was in a recent forum for vaccines the past 1 week, and then people trying to examine this concept and phenomena, whether we can simulate it for COVID to further break down the transmission. And there's we would like to simulate and repeatedly consider this for other viruses like RSV and COVID, to say if we were to vaccinate children, we're likely to provide protection. There are a lot of implications like cost and like possible risk of exposing so many children to certain vaccines, but would that make a huge difference to the whole community is yet to be studied. It has been already successful and it hasn't to be proven very well. I have showed some data and Dr. Nasreen have added along too.
Okay, thank you so much, Dr. Tariq. Dr. Nasreen?
I would repeat what Dr. Tariq said. I think the current program in most influenza vaccination program in most of the countries by vaccinating high-risk group is still working, still preventing, of course, morbidity and mortality in high-risk group. It's not optimum. So in order to optimize it, I think considering immunizing the school children with live attenuated vaccine would add to the protection, and it has really a positive impact on the public health. So using both together, in my opinion, would be more better than using inactive influenza vaccine alone, because of the problems that we face usually with inactive influenza vaccine.
All right. Thank you so much, Dr. Nasreen. And coming to the end, I would just like to summarize and put the most important point that we have learned today out of the two speakers' presentation. We have to know that influenza vaccine is not only a seasonal respiratory tract infection, but also it has its own impact on the community health in terms of mortality and morbidities. And we have to know that the vaccination improved the community protections, especially when it comes to people at risk, elderly populations, young populations, pregnant ladies, as well as people with comorbidities. And we have learned by the presentation, which has been presented to us elegantly, that children are more vulnerable to the infections, 2 out of 10, and adults 1 out of 10. But again, 50% of the children are the source for the infections for the elderly, especially those who are immune compromised. And we have learned also the life-attenuated influenza virus is safe, efficacious, and it will be a new modalities of enhancing a better coverage of the vaccine for influenza to the vulnerable populations. With this, ladies and gentlemen, I would like to thank you, and I would like to thank on your behalf our wonderful guest speakers, Dr. Tariq Moussawi and Dr. Nasreen Sharbini, for their wonderful contributions, for enriching our scientific gathering with a lot of information and updates and insight from their own clinical expertise. And I think what we have learned today was good enough for us to encourage us to go ahead and to promote vaccinations and recommend the vaccine for those people at risk. And I would like to thank AstraZeneca. Special thanks to Dr. Anas, who is along with us here today. And I would like to leave the floor for you if you would like to say a word before we close.
Thank you, Dr. Ashraf, for moderating the session, and thanks to the Saudi Society of Family and Community Medicine, and also for the speakers. They did a wonderful and amazing, informative presentation. Thank you, Prof. Tariq, and thank you, Dr. Nasreen, and also thank you, Multaqa Khibrat, for organizing this event. So thank you very much, and looking forward to see you again.
Thank you very much, Dr. Anas, and looking forward to see you, ladies and gentlemen, in a very coming updated sessions of the scientific sessions under the umbrella of the Saudi Society for Family and Community Medicine. Special thanks for Texas. We have here Dr. Abdul Hafid Khoja. Any words, Dr. Abdul Hafid?
في الحقيقة معليش أنا خلوني أتكلم بالعربي كما تعودت. شكر جزيل وعظيم للمتحدثين المتمكنين، سعادة البروفيسور طارق الموسوي، سعادة الدكتورة نسرين الشربيني، ولأستاذنا القدير سعادة الدكتور أشرف أمير على هذا المحتوى العلمي الرصين الذي استمتعنا به في هذه الأمسية والعلمية، وعلى الإلقاء المتمكن من المتحدثين الكرام، وعلى الحوار الجيد الجذاب منكم دكتور أشرف. الشكر موصول أيضا لشركة أسترازينيكا ممثلة في أخونا الكريم سعادة الدكتور أنس على هذا الدعم الذي نجم عنه هذا اللقاء العلمي الممتاز الذي زادنا علما وأبديت ومعرفة ومستجدات في هذا المجال الذي كان هو محور هذا اللقاء. شكرا لكم جميعا.
شكر موصول للجميع حقيقة، وشكر لكم إخواني وأخواتي الكرام الحضور، وأدعو الله سبحانه وتعالى أن يجعله علم نافع وعمل صالح ومنفعة ينتفع بها إن شاء الله لجميع أفراد مجتمعنا، وإلى أن نلتقي إن شاء الله في لقاء قادم قريب. لكم مني أطيب التحايا، والسلام عليكم ورحمة الله وبركاته. يعطيكم العافية. شكرا جزيلا لكم جميعا، دكتور طارق، دكتورة نسرين، دكتور عبد الحفيظ، دكتور أنس. نلتقيكم على خير إن شاء الله. في أمان الله.
شكرا في أمان الله. مع السلامة.
تصبحون على خير.